Let's now turn to the last of those 4 baskets of these 9 recommendations that were launched today, looking at healthcare systems integration. And for this, I'd like to invite a panel up onto the stage. I'd like to invite back Michele Calabro, who's going to be moderating this session, Director of Eurego, and bringing with him a lovely panel of Dr. Niamh Lennox-Chugani, who is the CEO of IFIC, the International Foundation for the Integrated Care, a clinician, academic and consultant. Welcome. We have Dorota Tomalak, Deputy Head of Unit, Secretariat General of the European Commission of the Committee of the Regions. Welcome to you. Also, Dr. Bart de Menere, Director at the Study Department Solidaris, and a medical doctor with a broad view from the Belgian health system. Welcome. And Dr. Lukianos Gatsoulis, who is a policy analyst at the Unit C2. Come and take a seat. In the International, where is he? State of Health Department. Health Technology Assessment at DG Sante. Welcome to this distinguished panel. Get seated, get yourself settled, and before you start your discussions, let's again remind ourselves about the patient. That came up on the last panel so much, about being patient-centric, or the point about patient rights. Let's take a look now at the next video. It's a testimonial from a lady called Jackie Brown of DESA. That's the Disability Equality Specialty Support Agency in Ireland. Let's hear what Jackie has to say.
Hello, everybody. Welcome. I am so sorry that I cannot be with you today, but at least I'm here virtually, and it's an honor to speak with you. I've been asked to speak to you a little bit about my experience as a patient and some of the challenges I had met in my own lifetime due to the lack of systems integration and health systems integration. And I lived with a lifelong disability and had many surgeries throughout my lifetime. I'm a thalidomide survivor, and I've had very good and poor experiences in health. In terms of the challenges that I've met, would be 3 that I would point out. One is about maintaining records, up-to-date, accurate data about my healthcare and my experience of healthcare, and about medications. I've also had challenges with medication errors, and finally, the 3rd challenge that would have been is the sharing of information. In terms of looking at, how a better integration of health systems would improve my quality of life as a patient, as I said, for me, my quality of life as a patient is all about my well-being, about my independence, about my ability to be part of my own healthcare journey. And so for me, that is about being able to interact with the healthcare system where we are breaking down barriers between what we refer to here in Ireland as silos. That's where different parts of the system operate like individual blocks, but don't talk to the others. So we really need to break those barriers and to get rid of as many silos and work in what we would call integrated care manner, so that the patient enjoy equality and equality in healthcare throughout Europe.
And forgive us if the sound wasn't all that clear on that. Just picking up a couple of the points there. She talked about the challenges she faced with the accuracy of records, some medication errors, and also she was concerned about the sharing of information and the silos. So an interesting panel. Over to you, Michele.
Thanks a lot, Sue, and I promise this is the last time you see myself today, so I'll start just with that. But yeah, so with this group of the UHealth Coalition, we really looked at the topic of health system integration as one of the 4 key pillars, and I think it's a topic that it's been really high in the agenda for quite a long time. But actually, COVID-19 clearly showed that there's still much to do to really truly achieve an integration of health system, of health policies within and across the member states in Europe and beyond. And when we talk about about health system integration, of course, we should take into consideration the different levels of integration in healthcare, and in particular, how these anyway should drive towards more continuity within health systems equally and across border as well. And we will touch on that point in the recommendation and in the discussion. And ultimately, integration, of course, we discuss about access to innovation. We discuss about how we can really connect with more efficiency in the health systems and deliver best outcomes for all patients, for all carers, for our healthcare professionals, for system management, government, and the industry as well. So we are really all on the same boat talking about integration of care. And I think this is another point that we'll touch later. And ultimately, I think as we're moving towards a European Health Union, the necessity of having more integration is clearly needed. And the way we wanted to finish, let's say, the introduction to our recommendation is without integration, there's no union. And to try to achieve some next steps, we focus on two recommendations that I think you should be seeing on the slides in a bit. The first one, implement effective EU health policies and program coordination, so a coordinated union, and how to do it through 4 policy asks that we included in our recommendation: strengthen and measure how health in all policies is implemented, actually, with a broad health impact assessment. Create this European Health Union multi-stakeholder partnership at all levels. It was touched already this morning, and it's clearly an important point of our recommendation. Move towards further cross-border cooperation, again, quite important to integrate across border. And then, of course, and we touched about this already several times today, elevate health workforce as a core pillar of the European Health Union and as a core element of integration of care. So we look at this first recommendation, let's build a coordinated union, and the second one, it's pretty self-explanatory, let's make progress on integrated care. And to make progress on integrated care, we touch 2 specific points: support health systems in adopting incentives towards concrete integration of care and the development of integrated care patient pathways through research and innovation, innovative financing models, payment linked to outcome metrics, and the development of a European framework to assess implementation. And the second point, equally important, of course, is boosting interdisciplinary skills in health workforce. So again, going back to the importance of health workforce in really delivering this change that we want to have with the European Health Union. But I will stop on this because, of course, we want to go to the panel today, and I will start now with actually a quick fire round of questions for everybody. You heard about the recommendation, you've also been following the discussion today. So starting with Luciano, so say, which is the recommendation in your view should be prioritized? Just a quick response, and then we'll go back to the details later.
Thank you, Michele, and good afternoon, everybody. I don't think I can pinpoint to one single aspect here, because there are so many that need to be tackled in order to achieve integration and move on and make the progress that we haven't made so far. If we focus only on one thing, our result will be suboptimal. That's why I would like to point to a few, for instance, the focus on health workforce and their skills for multidisciplinary work, the need for stakeholders to work together on many aspects, maybe the care pathways, maybe the payment models, maybe the cross-border collaboration. But all these things need to be supported, need to be addressed. We cannot do just one.
Thanks a lot. And coming to you, Dorota, what's your pinpoint, listening to the recommendation?
Thanks, Michele. I think coming from the European Committee of the Regions, it's quite obvious that my pick would be the cross-border cooperation. I know, listening to what's been said in earlier sessions, it feels like a little bit of a niche issue compared to some of the more systemic topics that we've covered this morning. But if you look just at statistics, I mean, 40% of regions having an external border, 1 in 3 Europeans living in these areas, it actually concerns quite a lot of people, this ability to have access to care not only in their own country or region, but also elsewhere. And it may be for simple, geographic reasons. It's closer to get to the hospital on the other side of the border. It may be the language spoken. If you're coming from Ostbelgien, it may be easier for you to talk to a doctor in Aachen rather than speaking French in Liège, for instance. Then also it may be simply a question of different care options that may be more interesting for your particular case. And finally, there may be a shorter waiting time. And we know that still many Europeans don't even know that they can go and buy their prescription glasses elsewhere, not just in the country, and get reimbursed for that. There may be those who know may be discouraged because of the paperwork that's needed or the complexity of the system. And finally, it still is a little bit of an option for more affluent citizens who can afford to advance, to pay, and then patiently wait for the reimbursement to come.
Thanks a lot, Dorota. Indeed, cross-border, of course, very important for the work that we do as well at Euriga. But I'll be back on that later. Niamh, and coming to you, what's the first thing in your mind when you listen to this recommendation?
Well, obviously, it's going to be let's make progress on integrated care coming from the International Foundation for Integrated Care. And obviously, I completely support Lucianas's assertion that we need to do, there's a lot of things that are interconnected. However, what I would say is really important to focus on right now is that whole issue of workforce investment and interdisciplinarity. And I would go beyond just workforce. Interdisciplinarity includes people at the centre of care, communities and caregivers. It's not just the health and care workforce. We need to be thinking more widely if we really mean to do something about integrated care that delivers on population health.
Thanks a lot. And last but not least, I'm coming to you, Bart. What's your first reaction on this? What would you prioritize?
I would also go for let's make progress on integrated care, because we have to make a healthcare shift if we want to keep it sustainable. And I refer to the workforce problem in all countries in Europe, I guess. And that's a problem we won't solve tomorrow, and also not the day after tomorrow. I think that's a problem we're going to take with us for a very long time. So we have to change the system, how we implement care to keep it sustainable. I just want to refer to the testimony, because I found it a very interesting testimony. And there, one of the messages was to break down all the silos. And I think that's an important message to take. All silos, not only in healthcare, but I think we also have to break down silos in politics. Because if we want a policy, health in all policies, we need to break down silos also there.
Indeed, the breaking down silos, I believe, was a very powerful message for the testimony. And definitely when you talk about integration, it's also something that you need to keep in mind very much. But I would like now to go back, like following up on your first reactions, starting with you, Lucianos. You mentioned, of course, that there's no one easy solution, of course. And it's hard to pinpoint what needs to be done first, because there are a bunch of things that needs to be done at the same time. Can you tell us more, especially from, of course, your point of view coming from the European Commission?
Certainly. So I think many of us talked about the workforce. Very briefly, I can say there are so many things to consider, and they have to do a lot with upskilling and reskilling. So integrated care can come with new roles, like case managers, care coordinators. There has to be some training for these new roles. There's a lot of discussion about how digital tools can actually become the glue that bring all the people together to work and deliver integrated care. So, digital skills required for the health workforce. But also this cultural shift that we are working together and we are making decisions together with the patients as well, and we are developing personalized care plans for patients. That is also something that requires upskilling and reskilling. About collaboration that I mentioned earlier, there are many stakeholders that will get involved in an integrated care pathway. And very importantly, there will be many payers and many service providers. And all of them need to work harmoniously. Because if this does not happen, then the delivery of integrated care will be suboptimal, it can fail, and it can be a waste of investments made. So there has to be attention to new governance contractual payment models that make this a harmonious living for all the stakeholders. And several approaches have been applied so far in some programs. Not all integrated care programs have applied such new models. They are complicated to implement. Sometimes they do not reach the predicted results. There is no solution that fits everything. We have to take into account the local context and the local ecosystem of stakeholders. But all of them pretty much relate to how the stakeholders share the same vision and ambition, and how they can work with the principle of sharing their assets, their risks, and their rewards. And you may have heard in examples that are called alliance contracts or accountable care organizations, or pay for performance, or bundle payments, or shared saving schemes. All these things have something to offer. Something that matches the context, matches perhaps the target group of people. But we need to explore more about this. I need to learn where they work, why they work well, what makes them successful, so they can potentially be more replicable. And I'll stop here.
Thanks a lot. No, you covered several points. I think the starting one is, of course, as we discussed already today, we do not have many resources, and we need to make the best use of them, of course, using all the tools and learning from what's working actually already in the fields. Thanks a lot, Lukianos. Dorota, I'm coming to you to follow up on, of course, your first reaction related to cross-border. So, you work for the Committee of the Regions, and we already discussed this morning how cross-border can also be kind of laboratory of European integration. Can you elaborate a little bit on the approach of the Committee of the Region when it comes to working cross-border between
Absolutely.
countries?
So just in terms of the context, the committee has been working on this issue for the last 14 years. I mean, both politically through opinions, reports, conferences, but also on a technical level throughout our consultation with regional hubs. So I'm talking about over 150 stakeholders in regions delivering cross-border care. So we're asking them very practically what works and what doesn't. What are your recommendations to put towards co-legislators, but also to the national level? And we've also worked within the so-called Fit for Future platform. So it's a more of a technical process of revision of certain acts of laws at the European level, where we also put forward a list of recommendations. So if I were to say in a nutshell really what we want, the answer is simple. We want more. And by more, I mean we want more information served in a more accessible way. I mean, I may have 3 university diplomas and speak several languages, but still when I go to the National Contact Point website and I try to understand what would be the care option that I would recommend to my great aunt, I still don't know the answer, honestly. It's so complicated that you basically need a PhD to just to read the information. Then second, it's not just about having information. I think we need to look more about brokering information, because one thing is to say, okay, well, you can check the article number 15 and then subpoint 10, and then that will give you maybe some options. No, each case is different, so some kind of brokerage is needed to make informed choices for patients, through patients group, but also through public authorities that do have a role to play, I believe, very much in this field. Then something that Lukianos just mentioned, the local ecosystem. We need obviously some global solutions, we need European solution, national solution, but we also need flexibility for regions, because each situation on the ground is different. So we are also advocating very much for more flexibility, more leeway to border regions to actually solve technical issues or maybe administrative issues that hamper their cooperation. And I mean, you all know the stories about ambulances not being able to cross the border because it emits few decibels more, or the shade of the siren being more green than blue, and that is creating a major problem for that ambulance to cross. And obviously people are coming with creative solutions, having 2 sets of ambulances for one clinic, or always listing in the log that it was an accident, actually. So they were picking someone because it was an accident, and that would enable them to cross. But these ad hoc solutions are not really systemic, so we need something more systemic and flexible. Then also, when I'm looking at more sort of European level, what we've heard a lot, what would help would be actually to have some kind of a single European bill when it comes to cross-border care provision. I'm not saying one bill for Europe, but at least in this cross-border sector, it would be helpful for insurance, for public authorities, and ultimately for patients to know, okay, well, item 1 is what I got, item B is what they prescribe, etc., etc. Then, I mean, I'm thinking big here, but the full rollout of electronic health records and any prescriptions would be just marvelous. But also the greater recognition of professional diplomas. I mean, the original 5 is already okay. Well, implementation is slightly patchy, but there is more work to be done. And yes, as the panelist before was saying, yeah, let's hurry up with that. Then also issues around prior authorization and direct billing. We know that this is the major issue for people willing to cross, the fact that they will have to advance the money. Some know how much, some do not, and this is causing problems. So, well, why not think big? If you already have a promise from your insurer, okay, well, we will reimburse you up to that level for that intervention, then why not asking the provider to actually send the bill directly, if the promise is already made anyway? I would also, bring another ask here, maybe more networking opportunities for regions. It's always getting through contacts, information, and everything. And finally, we've seen that with COVID, how dangerous it is to actually close the borders and cut off all cooperation that is ongoing. I mean, if you were, living in Lorraine and you had that opportunity that if something happens to your heart, you can be taken to the clinic in Völklingen, and suddenly, bam, there is a border, and you will have to be driven 200 kilometers to the nearest hospital because that Franco-German cooperation is not possible actually to be implemented at that very moment. That's dangerous for patients, that's disruptive. So that would be my big ask. If there is another situation like pandemic happening, let's keep the borders open for healthcare professionals and for patients.
Thanks a lot, Dorota. You clearly highlighted how complex is integration, even cross-border and close partners maybe already. So that's really good. Before I go to you, Niamh, I would like to of course remind that you can send questions to Slido, and then so start thinking about it as we're gonna come to the audience in a bit. I will try to of course post some of the questions to the panelists. So Niamh, I'm coming to you. Of course, you highlighted greatly the importance of health workforce. Again, let's work towards integrated care. But what is to be done? So really, what's the first thing you think about when you come to preparing workforce for integrated care?
So again, I would slightly turn that question on its head and say what is already being done. I would also expand what we call the workforce because, and again, I was trying to find the etymology of the word workforce the other day because it's a word I feel really uncomfortable with because it implies a quite boundaried resource, which we know in health and care we don't necessarily have because there are a whole range of informal, in fact, most people who care are informal carers. So yes, we need to focus on the workforce, but it has to be much wider than that. So if I look at what we know is already being done to support and develop those who are working in health and care, we know that there are pockets of development or focus and investment on development, not in the EU necessarily. So we know that in England, for example, and Northern Ireland, they're actually doing quite a lot of work to invest in preparing their workforce for models of integrated care. But also in Ireland, they've started thinking about that now very proactively with funding from DG Reform, for example. They've also been doing that for a number of years in the Netherlands, in Catalonia, in the Basque region. So there are examples there where there has been investment in the workforce to deliver new models of care and interdisciplinary care. But one of the things that I would urge policymakers is to stop seeing development, workforce development, as a cost. and start seeing it as a value and an investment that has a return on investment and a return on investment very, very quickly. Too often we see when health and care systems have to make resource allocation decisions, often the first things to go are the training budget, but also development. Development is not just about training, it's about 20% training, it's 80% being given the time and the space and the resources to work and learn together and build in feedback loops to your learning. So that would be my urging to policymakers, is to not ignore the importance and value of developing the workforce.
Thanks a lot, and I think you touch on the point of investing in health, whatever the investment is, it's a return of investment. So it's not just a cost; it really needs to be seen as an investment. That's great. Thanks a lot. And Bart, I'm coming to you, of course. We talk about breaking the silos, and we also want to see what's happening already. So how is integrated care being brought forward in Belgium, for instance? How do you see these silos breaking happening?
We already did partially. I'm going to say it like that. I first want to add to Niam, I think you need a broad support base with healthcare workers, but also with patients, to move towards integrated care. And that's a big effort. And as she said, I think we need to invest in that before we can have integrated care as a success. In Belgium, we have a model for diabetes since 2009. The objective in 2009 was to develop 9 so-called care trajectories. We only developed 2 until now, one for diabetes and one for chronic renal failure. But the most successful was for diabetes, where we made a trajectory in first line with responsibilities for patients and caregivers, where patients have to keep controls during the trajectory. They have benefits on costs and on administration for medication that's not easily reimbursed. If they don't follow the rules, I'm going to say it like that, they lose the benefits. And for caregivers, there's a responsibility to deliver materials to patients, to register, so we have data we can follow. And each year, we do an evaluation of those trajectories, and it shows that we have a rather good control of those patients. Where we still not succeeding after 13 years is, and I think it's also a big issue in integrated care, that's the group that's starting in diabetic or is even not aware of having diabetic. There we don't succeed in finding those patients, taking them, if you can call them at that moment patients. There I think we still have work to do, but in the first line we have a trajectory where first line general practitioners are supported from specialists, from secondary centers. We have a next model in a convention system where there are also responsibilities, incentives, and also registrations, and where we see that we keep to connect with the story of the data, the HbA1c compared to other countries are much better controlled in our system compared to other countries. So it means it works, but it's a work that takes a long time. I think we have to be conscious that starting integrated care is a process of long duration. We are now in Belgium, we have started other pilot projects, and we are now working on a national plan for integrated care to go much further. But the biggest obstacles are patients are not ready, and above all, caregivers are not ready, and we have to get them ready to get in the system, because otherwise you can make data, you can make integrated files. If your caregivers are not willingly or ready to work together, it won't work. But the system works, and I think it's a great model to do other chronic disease. It's a little bit the discussion. It's a disease-related pathway, and that's not always the good pathway. So we're trying to find a more generic pathway. But I think it's also a model that can be example for other regions or other countries, sure.
Thanks a lot. No, and that actually, upon that, that I wanted to start with you. Indeed, what can be learned from Belgium? Like, if there's one thing, you know, you say to another country that is starting to look into that, the first thing that you say, start from that.
Yes, come and have a look at our model and see how we, in a trajectory, patient pays less out of pockets. The caregiver is paid a fee, but a global fee, not for service, but a global annual fee to follow up the patient. The material is cheaper in the trajectory than outside. Medication that's normally seen is a very administrative burden to get the reimbursement is easier once you're in the trajectory. It's all kind of systems we implemented. There have been changes during the last years, but it's a model that works, not for everything, I think, but for a lot of things. There are concepts in it that can work and that we can, enlarge to other diseases or to a broader system, but also to other countries. I don't know if every country is going to be good with that model. It depends on every system in every country, but I think there are elements in it that can be used and that are probably yet used in other countries. I think everybody is moving ahead. What we see is that we move ahead, but at a rather slow rate. We have to take time. I don't think we have fully integrated care tomorrow, and also not the day after tomorrow. But gently, you break down silos piece by piece. You cannot break them all in one day. But I think that's the way to go. And now we are speeding up, I would say, on a national plan. Wait and see how it's going to evolve and what's going to happen. But we have faith in it, yes.
Well, that's the most important thing, having faith and learning from each other, I would say. Luciano, so I'm coming to you, actually following up on this. So, of course, I think we all agree that integration of care is fundamental to the transformation of health systems. Yet, you know, they are very good examples, and somewhere else, maybe we're still lacking behind. So, what can we do to focus on in order to facilitate wider deployment of integrated care? And following up to that, how can the EU support that in terms of integration among health systems?
I will try to simplify, and it's a very complex business, integrated care, but I will try to simplify it down to two axes of, let's say, the absolutely necessary support to get moving and make some progress forward. The first one is make financing available for investments, because without investments we cannot progress much. The investments in the health workforce is one particular example that we heard already. The second dimension is we need to provide support to build the capacity of national and regional authorities to implement, to design and implement integrated care. And this has many sub-directions, anything from putting all the stakeholders together to align the vision, patients on board, caregivers on board, as we heard, pathways, the payment models, the training, all these things. For many regional authorities, it's still like a mystery in a black box. Where do we start? What do we need to do step by step? And I would like to say, and I strongly believe this, that from our side in the Commission, we try to provide support on both of these two major directions. I'll give you some examples. So a few years ago, I think it was back in 2017, the expert group on health systems performance assessment produced a report on integrated care, which outlined what are the building blocks, the system levers to design and implement integrated care. The report had a very extensive annex of examples from regional settings that seemed to work well, and explaining what were the success factors and what are the transferable elements. And of course, the report concluded with a set of indicators and a framework how to assess the implementation of integrated care. Then we had a number of projects who did very specific things to try to, let's say, open the eyes and test things. So a project developed a tool called the maturity model, the Sirocco project, funded by the health program. This was like a self-assessment tool for regions and national authorities to assess how ready they are to embark on the deployment of integrated care, and even how ready they are to adopt a good practice from elsewhere. Another project, the Joint Action Jade Care, tries to work on the actual transfer of best practices. So there are 4 best practices on the table, and there are about 20 or more new adopters of these practices. So we're trying to see how feasible it is to actually do a transfer process. Adjusting it, of course, we know that it cannot be a copy-paste business, but adjusting it. Then we have a very specific program that offers technical support, which is managed by DG Reform. In the previous years, it was called the Structural Reform Support Program, and now it is called the Technical Support Instrument. A few years ago, Estonia received support from DG Reform under the older program to develop a strategy for the provision of integrated care, to develop care models, and even incentives for payment models. And now our colleagues in DG Reform have launched this year a flagship initiative under the Technical Support Instrument, which is called Towards Person-Centered Integrated Care. So member states, back to the 31st of October this year, could have made requests for technical support to be assisted to implement strategies, to design strategies, to implement reforms on integrated care. So we will see how many of these requests will materialize into actual support projects. When it comes to funding, already in the past, the cohesion policy funds financed at regional level the implementation of integrated care, and this of course can continue in the new programming period. We also have this new kid on the block, the Recovery and Resilience Facility, which was born out of the need to respond to the pandemic. So some member states in their national recovery and resilience plans do foresee reforms and investments in integrated care. And coming a little bit into the future, coming ahead of us, the Horizon Europe Partnership on transforming health and care systems. That can also deal with integrated care implementation. So that's a package, if you want to call it like this. I would like to consider it as non-negligible things that we try to do on integrated care.
Absolutely, no. It's definitely a lot, and even much more can be done, of course. But before we go to the final couple of questions, I want to bring up a question from Twitter, actually, and maybe a couple of you can actually provide a response to it. So the question is to Bart. You mentioned that patients and caregivers are not ready for collaboration on integrated care plan. Why do you think this? And maybe also want to bring Niamh on this question. Do you feel there is preparedness on bringing patients and carers on integrated care, on integrated care pathway? So 1 and 2.
I'm gonna say that not all caregivers are ready, but a part of them are ready to embark in this journey of integrated care. But there is, and I think it's a little bit historic, but also pending on the actual system. We are a very fee-for-service system. We are moving towards other financing models, but it goes slowly. So I think there is a certain resistance to entering that integrated care model in fear of how is that going to influence my status, my finance, my income. I think it's a sort of thing to they're not, how would I say it? They've got a little bit fear to enter in the system. So we have to take that fear away and make them comfortable with the way to go to integrated care. But a part of caregivers already, that's the same thing for patients. I think some patients are very willingly to enter in a system like that, but for most of them, they're used to a system that was completely different. So it's a sort of, yeah, you have to take a step to enter, and for some, that step is difficult. And I think we have to invest hardly to get those people, even patients or caregivers, to enter the system, to give confidence in a system of integrated care. But it's also a job of a government to create a sort of culture about integrated care that helps people to enter into the system.
Niva, coming to you, if you have a comment on that, and then I see that there's a question from the public. Then another one.
I think Bart and I are completely philosophically aligned on that. Where I think we might differ slightly is I don't see the health system as having an entry point for people and caregivers. I think health is what we're trying to create. It's not a gift for us to give to people. I think it's about, part of it is about changing the language around I think somebody talked about the word engagement not being the right word, and I think that's absolutely right. It's how are we working with communities, with people, with caregivers to design our health and care systems in a way that enable them to live the healthiest, longest lives they possibly can. And that is the reorientation that is the biggest challenge, I think, to policymakers and to practitioners within health and care systems, is to recognise that we know from recent research in Canada, for example, and I can't imagine that Europe is very much different, that actually less than about 5% of health and care is provided by statutory providers within health and care systems. That means 95% of care is happening somewhere else. And a lot of it is actually self-care. So unless we're really committed to working closely with people and communities, we're not going to deliver on the promise of integrated care.
Thanks a lot, Niamh. I'm coming to two very quick questions. Yes, 1 and 2. So I'll start with you. If you can introduce yourself, be concise in the question. Thank you. Doesn't work.
Perhaps it does?
No, yes.
So, hi, I'm Jeanette Soderberg from JDRF, again, a diabetes patient organization. And I wanted to comment on this model that Bart was talking about. And of course, we need incentivization of people to take care of themselves. But I just want us to be very mindful of how we talk about it and who we're incentivizing. So we don't develop a model where we are punishing people for having a disease, where we're not looking at, are your blood glucose levels good enough for you to merit health care? And that we don't end up in a situation where we are actually punishing people who are underprivileged. Like not all of us can take a half day off to go and see their doctors during working hours. Some people have jobs, they'll get fired if they do. Some people can't afford to take their insulin because they can't pay the out-of-pocket cost to get it. And some people actually are living in an environment where they don't really know how much food they will get at their next meal. And having a model where these people can't access care or are being punished for not following what we expect from them, these people merit more support and more help rather than being excluded from healthcare. That's my only point.
That's a good point. Like again, we go back to avoid creating further inequalities in a way. So that's a really good point. We have a question. Back there, and then Marilyn, and then we go to the final round of comments. Yes, behind. Yes.
My name is Antoine Poppe, and I tried to develop the Ultimate Health app. And I congratulate the organizers for the very informative meetings. But my question is, or my remark is that, first of all, we are going towards one of the largest and the biggest economical crises ever. So I think that health will become even super important for the people, especially all the people who will be delayed and all that. So my next question is then, why does the European Commission not look at what was already achieved in Europe? And for that I look to Estonia. In Estonia, the whole health system, and in fact the whole system, the administrative system as well, in Estonia is totally digitized. Yeah. So why doesn't Europe start by obliging all member states to digitize their health data, and on the basis of the health data, we can start to develop all kinds of, how would I say, monitoring devices, monitoring systems on your smartphone, which everybody has in his pocket. And that will bring an immediate, simple solution to give all citizens the authority over their own health, which they don't have at the moment. So another complementary to that is that why does the European Commission doesn't set up a center of excellence, people who look around in Europe what research and development is done in the medical sector, which is too far ahead of the actual situation, and why don't we equalize the knowledge and the technologies used in European unity, because we are Europe. So we should become all on the same level as far as medical service is concerned. And as I said, we will need it very urgently because a huge economic crisis is coming on us. Thank you.
Thank you. I think there are still 2 questions, Jacqueline, and here in front. And then we go with quick answers if you want. So think about if you want to address one of these points, and also think about the take-home messages that you want to share with the audience.
Yeah. Hello, Jacqueline Bowman-Busato, representing the European Association for the Study of Obesity. I actually have, I'm hoping it will be a simple answer question, because I remember I was there in 2011 when we went through the original NCD planning, and we all did a lot of work, what was then being called chronic conditions, and we talked a lot about integrated care, and we moved from what was essentially primary and secondary service delivery sites into community and digital and all these things. Now, something that I really was struck by with what you were saying in particular, Bart, was that we needed to go beyond the silos. But, and it's a very big but, what I'd be interested in knowing from you and also other panelists briefly is, how do we do that in a world where we talk about health outcomes, where we talk in a world about integrated care, but we don't seem to be going beyond one or other chronic condition / chronic disease and actually going upstream. So of course, obesity, gateway disease, 80% of type 2 diabetes, 20% of adult preventable cancers, 236 medical complications. So it's something that our community of 20,000 plus across 36 WHO Euro region countries, we're very concerned with, from the health professionals, researchers, investigators, and public health professionals' perspective. So I would really love to hear some reflections on how we can achieve this.
Perfect.
Thank you.
Marilyn, and then we go to the answers and final question.
I'll try and keep it very short because in the interest of time, and Jacqueline's more or less said what I was wanting to say, but I think if we look in terms of integrated care, it's a very loaded term, integrated care. What do we mean by that, and what does it mean to a lot of people, especially now that we're looking at self-care, self-management, economic crisis, and so on and so forth? Is there a way that we could actually simplify what is meant by integrated care, training, whatever? Maybe it's a role for us here at the Coalition to actually even just produce a one-pager or something that will give, as you said, the patient organizations a start to be able to identify and see where we go from there. As I said, we could talk about it all day, I know, but I'll keep it at that.
It's a good point. So like starting to talk the same language in a way. So I'm going to close the meeting now with a quick round of responses from each one of you. So maybe I'll start with Niamh here. So take-home messages if you want to address some of the questions that were made.
Okay, I'm going to do a very quick fire round of addressing each of the questions. Estonia, the project that Lukianos referred to, the foundation actually led that work for 3 years in Estonia. Estonia has a great deal to say about digitisation. However, I would say their journey to integrated care is probably at a very similar level to many other countries in Europe, and they're facing exactly the same challenges, and they, I think, would agree and say that actually digital isn't the answer to everything. It is a very big part of the solution, but it unfortunately isn't a panacea. On the moving from past chronic conditions, absolutely. As a foundation, we have been on that journey since 2011 and are starting to see a shift away towards the use of integrated care as a mechanism to deliver population health. On how we define integrated care, well, that discussion's been going on for 20 years. And frankly, as the foundation, we've stopped having it because there's no point. Integrated care means different things to different people. What we do say is there are 4 key tenets. There are 4 key principles and elements to integrated care. It has to be person-centered, community-centered, coordinated, and continuous. That is what integrated care means to people. And we know that because we've also tested that with our recently published first annual survey on integrated care, which went out to our global network of 30,000 people. And that message came back as resoundingly from users of services and caregivers as it did from practitioners and policymakers. So if I was to round up what the take-home message is, we have to start bringing together all the knowledge we have around integrated care, and I think I've heard that from lots of people today. Do we need a centre of excellence? Probably not. We just need to make sure that we're not losing what we've already learnt. And I think that's a challenge for policymakers everywhere. Every time there's a new political cycle, there's a little bit of organisational memory loss. We need to work really, really hard to ensure that doesn't happen. At the foundation, we try and collate all of that information around integrated care. A lot of resources are available on our website. A lot of the initiatives that Lukianos has talked about are still available through the foundation as well. So that would be my plea. Let's not lose everything that we've learned.
And a lot of the learnings and best practices are coming from regions. So Dorota, coming to you for a closing message, if you want to address some of the questions that were made.
I think I want to pick up that last comment on, indeed, on definitions of, or on how we understand integrated care, because that's something we see a lot in the Committee of the Regions, where people don't necessarily speak English like we do here. So when they come and we throw all these terms at them, you know, integrated care, whatever, mainstream, streamlined, etc., you add all this nice EU jargon, people's faces just go blank. But once we start talking about details, they keep telling us, okay, well, for us, in my locality, we actually started working, you know, with GPs and hospital managers together. So they see integration between primary, secondary, or they would see integrated care as care, physical and mental well-being, for instance, brought together. Or elsewhere, they would think about the social and health care being integrated, and that would be for them a model of excellence for integrated care. So I don't think we can say there is one answer to that. And there is a richness in these different approaches, what people perceive as a right solution for the region and a right solution for their community. So I'd very much agree with what Niamh just said, that we need just more sharing of this information, more cross-fertilization, more talking about what we're doing on the ground with the resources we have and the problems we have. And just my final comment here is, we know that 70% of Europeans want more involvement, more Europe in health. So there is a clear mandate to actually go forward to do more. And I think we need to take that mandate, that permission, and actually be bolder in making that happen.
Thanks a lot, Dorota. 1 minute comment from each one of you. Bart?
Okay, can be short. No, integrated care is a vast thing, and I think everybody has problems to grasp it and looks at it at its own level. And I follow Niam. You have to have some sort of core elements to say that's what we understand, and everybody got its own language. And I'm going to terminate with a message. Today is in Belgium Dynasty Day. And we've got a national motto, and I think it's a very good motto for integrated care. I'm going to say it in French. L'union fait la force.
That's a very good message indeed. Lucianos, coming to you for a final comment.
Some quick reactions and a final comment. I think we have to acknowledge that for those who wanted to start doing something on integrated care, the easiest way to do something was to focus on a disease and integrate the care around the pathway for that particular disease type. But of course, the future is go out of that and totally encompass everything, especially for patients who suffer from multiple conditions. So let's accept that this is for many the starting point, because you need to start from somewhere. You cannot achieve this, but then you should not stop there and move on. I would also like to remark that the Commission cannot actually oblige or dictate to Member States what to do with their healthcare. It is their responsibility to organize and deliver healthcare according to the treaty as well. We have to respect that. But the Commission can support them to do many things. And my final comment touches upon that first of all, we need to consider continuing and expanding the work with stakeholders to uncover and disseminate innovations, evidence, and good practices, according to what Niamh was saying as well, and use that to support Member States improve the health systems in many aspects, including integrated care. So the aspect of continuing to offer support for me is crucial here. Thank you.
Thanks a lot, and indeed stakeholders are here in this room, I would say. Sure.
Thank you. It's a pity to have to try to bring this to a close because there's so much in there and, again, so much more that we'd love to discuss. But what an interesting panel. Thank you so much. Thank you for moderating the session, Michele. Thank you for your great, distinguished speakers. Please join me in thanking the speakers.